Welcome back to the Deep Dive. Today we're looking at some unsung heroes in healthcare. Not the ones you immediately picture, maybe.
Right. We often think of doctors, nurses, researchers in white coats, and absolutely, they're critical.
But there's this other force working silently behind the scenes. It's data. Specifically, the aggregated, anonymized data from all of our everyday health experiences.
Exactly. EHRs, pharmacy refills, patient feedback, all that real-world stuff. It's becoming this incredible engine for discovery, especially for the really big, complex health policy questions.
So that's our mission for this deep dive, to really get into some concrete examples, some life-saving wins where real-world data RWD directly changed health policy and, made things safer for patients. For you. Maybe we should start with the basics, though. Just quickly, what exactly is RWD?
Sure. So RWD is pretty much any health information that's gathered outside of a traditional controlled clinical trial.
Okay, like my electronic health record.
That's a big one. Also, insurance claims data, information from patient registries, sometimes even data from like fitness trackers or other wearables. It's the data generated during routine care.
And when that data gets analyzed properly,
that's when it becomes real-world evidence, or RWE. You apply rigorous methods to that messy real-world data to get insights you can actually trust and act on.
Got it. But why do we need RWD? We've had randomized controlled trials, RCTs. For ages, they're the gold standard, right?
They absolutely are the gold standard for proving if a treatment can work under ideal conditions. Very controlled groups, strict protocols.
But the real world isn't ideal.
Not at all. It's messy. People forget to take their meds. They might have multiple health issues. They come from all sorts of backgrounds, ages. RCTs often screen out that complexity.
Oh, okay.
So RWD shows us what actually happens when a treatment gets out there to millions of very different people. Its real power comes from scale, millions of patients.
Which you need to spot rare side effects, for example.
Exactly. Or to understand how a drug works long-term. Or if it works differently in, say, the elderly versus younger adults, or across different ethnic groups, people often underrepresented in trials.
That difference between can work in a trial and does work out here, that seems key. Let's jump into the first story then. You mentioned spotting rare events pharmacovigilance. Sounds like a digital watchdog system.
That's a great way to put it, yeah, pharmacovigilance. So imagine this. A fantastic new drug gets approved based on solid but maybe smaller clinical trials.
Okay.
It starts getting prescribed to millions. But maybe there's a really rare side effect, something serious, like a specific type of liver injury that only affects, say, 1 in 50,000 people.
Wow, okay, so one doctor, even a specialist, might never connect the dots just from their own patients.
Almost impossible. They might see one case, maybe two in a career. Not enough to establish a pattern confidently. It's just background noise at that level.
So how does RWD find that needle in the haystack?
Well, regulatory agencies and researchers use these huge linked real-world data sets. Think networks of hospital EHRs or national insurance claims databases. Like the FDA Sentinel Initiative in the US is a prime example.
Okay.
They proactively scan this data. They might compare, say, 200,000 people starting the new drug with 200,000 people starting an older, similar drug. They're looking specifically. Is the rate of that rare liver condition higher in the new drug group?
But hang on, isn't that data super messy? Different hospitals record things differently, and maybe the people getting the newer drug were just sicker to begin with. How do you account for that?
That is the central challenge. You're absolutely right. And that's where the rigorous analysis, the E and RWE, comes in. They don't just compare raw numbers.
Right.
They use complex statistical methods, things like propensity score matching or stratification, to adjust for all those differences: age, other illnesses like diabetes or kidney disease, maybe even socioeconomic factors if the data allows.
So you're trying to make the groups as comparable as possible, statistically speaking.
Exactly. Trying to isolate the effect of the drug itself. It requires really careful data cleaning and sophisticated analytics, comparing apples to apples as much as possible.
Okay, so they do all this statistical heavy lifting. What happens when they find a real signal, like in the liver injury example?
In cases like that, the RWE might show a clear, statistically significant increase in risk. Maybe that liver injury is 4 or 5 times more likely with the new drug.
So what's the impact? Do they pull the drug?
Not necessarily. And often that's not the best outcome if the drug is otherwise very effective for many people. Instead, the RWE leads to targeted action.
Like
adding a black box warning, that's the FDA's strongest warning, right on the drug's label, highlighting the risk. Or developing new clinical guidelines, maybe recommending regular liver function tests for anyone starting the medication.
So you manage the risk, you don't just eliminate the drug.
Precisely. It refines the drug safety profile. It means patients who really benefit can still get the drug, but under much safer monitored conditions. It prevents potentially thousands of severe adverse events or even deaths, all thanks to this behind-the-scenes data vigilance.
It's a massive patient safety win that most people probably never even hear about.
It really is. And it underscores that drug safety doesn't stop once a drug hits the market. RWD enables continuous monitoring.
Okay, so that's using scale to find rare dangers, but can RWD also help tailor treatments? Move beyond that one-size-fits-all approach? Let's talk about optimizing treatment for different groups. Hypertension, maybe? High blood pressure?
Yeah, hypertension is a perfect example. For years, clinical guidelines often recommended a standard first-line drug class based on the big RCTs.
Okay, standard practice.
But clinicians out in the real world were noticing, anecdotally sometimes, that it didn't seem to work equally well for everyone. Maybe less effective in certain racial or ethnic groups, or perhaps riskier for older patients who also had kidney disease, for example.
So the real-world experience was hinting at nuance that the original trials maybe didn't capture.
Exactly. The trials give you an average effect, but the average patient doesn't really exist. So researchers used RWD again, large de-identified EHR, and claims databases to ask a different question.
Which was?
Not just, does this drug class work, but which drug class works best for which specific types of patients in the long run, looking at actual outcomes like preventing heart attacks or strokes.
And because the datasets were so huge and diverse,
they could finally drill down into those subgroups that were maybe too small in the original RCTs or were excluded altogether.
What did they find? Did it confirm the clinician's suspicions?
It often did, and sometimes revealed even more. The RWE might show, for instance, that for patients of specific ancestries, a different class of blood pressure medication was actually significantly better at preventing those major cardiovascular events than the standard recommendation.
Wow.
Or, for older patients who also had kidney problems, maybe a third drug option was clearly safer and more effective based on the real-world outcomes data.
So this RWE wasn't just interesting, it actually changed medical practice.
Fundamentally. This kind of evidence forced a major shift in clinical guidelines. Instead of one single first-line drug for most people, the guidelines became stratified. Meaning they now recommend different starting therapies based on factors like a patient's race, their age, other health conditions, these are comorbidities. It's using population data to enable more personalized medicine at the point of care.
So millions of people are potentially getting better, more tailored treatment now because of insights dug out of RWD.
Absolutely. Better outcomes, fewer side effects. It's a huge move toward optimizing care.
Okay, from rare events to personalized care. Our third story feels incredibly current. RWD in a crisis, specifically the COVID-19 pandemic.
Oh, absolutely. If ever there was a time we needed fast, relevant evidence, it was early 2020. Traditional research, like launching brand new RCTs for everything, was just way too slow.
The virus wasn't waiting. We needed answers yesterday about who was most at risk, how it was spreading, and later, critically, were the vaccines working in the real world?
Right. The initial vaccine RCTs were crucial for authorization, showing they could work. But the questions kept coming. How well do they work against new variants? How long does protection last? How effective are boosters? RCTs couldn't keep pace with those real-time needs.
So health systems globally turned to RWD.
They had to. Countries like the UK with the NHS's linked data, Israel, places in Scandinavia, large integrated health systems in the US, they rapidly mobilized their RWD infrastructure.
Linking hospital data, vaccination records, testing results.
Exactly. They used this linked data to compare outcomes, hospitalizations, deaths between millions of vaccinated and unvaccinated people. This gave us the first really solid estimates of real-world vaccine effectiveness.
But again, the challenge must have been huge. Vaccinated and unvaccinated populations are different in so many ways beyond just vaccine status, age, health behaviors, risk exposure. How did they untangle the vaccine's effect from all that?
Massive statistical effort. Again, it comes back to that rigorous analysis. They used advanced methods, things like test-negative designs, sophisticated matching techniques, adjusting for dozens of potential confounding factors simultaneously. It wasn't perfect like an RCT, but the sheer scale of the RWD allowed them to get remarkably reliable estimates quickly.
And those estimates directly guided policy.
Immediately. RWD also rapidly identified key risk factors for severe COVID, things like obesity, diabetes, heart conditions.
Ah.
That information was critical for deciding who needed vaccines first, who needed stronger protective measures or shielding policies.
It became like a real-time dashboard for the pandemic response.
It really did, and it went beyond just acute illness.
Yeah.
RWD was also essential for starting to understand and characterize long COVID, its symptoms, its prevalence, which was something largely invisible to traditional infectious disease surveillance early on. It helped spur the research and the creation of specialized clinics.
So in that crisis, RWD wasn't just a nice-to-have, it was foundational.
It was arguably the most important source of timely evidence guiding global public health strategy, from prioritizing vaccines to timing boosters to communicating risk. It showed RWD's power in an emergency.
Okay, let's pull back now. We've seen RWD tackling rare drug side effects, tailoring treatments for hypertension, and guiding the response to a global pandemic. 3 very different areas. What's the common thread here? What are the big lessons from this RWD revolution?
Well, I think the first overarching lesson is just the incredible power of scale and diversity. None of these insights were really visible, or at least provable, until you could analyze data from millions of different people living their actual lives.
Things that get lost in the average of smaller trials.
Exactly. The rare event is too rare. The subgroup difference is too small to be statistically significant in a typical RCT. Scale unlocks that.
You also keep mentioning linked data. How crucial is that piece connecting the dots between, say, a prescription and a hospital visit?
It's absolutely critical. The most powerful RWE stories often come from linking different data types, connecting pharmacy records to clinical notes in the EHR, maybe linking that to hospital admission data or even mortality registries. That gives you the full picture of the patient journey and outcomes.
But that sounds technically and logistically really hard, all these different systems.
It is incredibly hard. That's probably the biggest bottleneck right now. Data standardization, interoperability between systems, navigating privacy regulations across different data sources. It's a huge challenge. The successes we talked about represent the vanguard, where a significant effort has been made to overcome these hurdles. Most healthcare data is still pretty siloed.
So a reminder that the potential is huge, but the plumbing isn't fully there yet everywhere. What about the human element? Is this all just algorithms crunching numbers?
Not at all. It's very much a partnership. The AI and advanced analytics are the tools that let us sift through these massive data sets at speed and scale. But humans, the clinicians, the epidemiologists, are the ones asking the right questions.
They see something in practice, have a hypothesis.
Exactly. They notice the potential side effect, or that a drug seems to work differently in some patients. They design the RWD study to test that hypothesis. The AI finds the patterns, but human expertise directs the search and interprets the findings. Clinical intuition is still vital.
And underlying all of this, especially when you talk about linking sensitive health data, is the ethical dimension, trust.
It's the absolute foundation. None of this works if the public doesn't trust that their data is being used responsibly, securely, and ethically.
Anonymized properly.
Yes, with robust privacy protections, strong security measures, and clear ethical oversight from institutions and review boards. If that trust erodes, people might opt out, data sharing stops, and this whole potential for learning and improving care just evaporates. It's an ongoing commitment.
So when you put all these pieces together, the scale, the linkage, the human-AI collaboration, the ethical framework, what does it point towards?
It points towards what people call a learning healthcare system. The idea is that the healthcare system itself continuously learns and improves from every single patient interaction.
So my visit to the doctor, my prescription refill, anonymously and ethically used, helps make care better for the next person.
That's the core idea.
Yeah.
Every experience contributes a tiny piece to this huge pool of knowledge that refines guidelines, improves safety, and personalizes treatments. It's a really powerful and, I think, hopeful vision for the future of medicine.
It really reframes our own healthcare experiences, doesn't it? We're not just receiving care, we're contributing to collective health intelligence in a way.
In a very real, tangible way. The stories today show it's already happening. That data is actively saving lives and shaping better health policy behind the scenes.
So the journey of using data responsibly in healthcare is something we're all participating in. The potential is clearly enormous.
It is, but it needs ongoing support. We need continued innovation, not just in the fancy algorithms, but in the unglamorous work of data standards, interoperability, and crucially strong policies that protect privacy while enabling this kind of vital research for the public good.
Trust in the responsible use of RWD seems like the critical ingredient for building that healthier future.
Absolutely essential.
Well, thank you for walking us through these incredible stories. It really highlights the hidden power within our collective health data.
My pleasure. It's a fascinating and really important area.
And thank you for joining us on this deep dive. Maybe next time you see your electronic health record, you'll see it not just as your personal file, but as a small piece of a much larger puzzle that's helping keep us all safer and healthier.